Today I am going to cover outcomes of IVF pregnancy. We all know 10 million children have been born globally by IVF, and every year we are doing 2.5 million cycles. So approximately 5 lakhs children are born annually. So it's a huge number. And why these pregnancies are special? Because these patients are under a lot of mental, social, physical, financial stress, and stress make them prone for abnormal hormones and blood pressure problems. These patients are usually having a pre-existing disease also, like adenomyosis, endometriosis, which make pregnancy special and high risk. These patients are more prone for corpus system dysfunction in fresh cycles, because at the time of aspiration, we aspirate few follicle cells also. And
the slides are not.
sorry? Hello, Shalini?
Slides are visible.
Okay, yeah. Am I audible?
Yeah.
Yes.
Yeah. Go ahead.
I'm already talking, so should I start from the beginning?
No.
And these patients
go ahead, continue from
pregnancy-related complications like PET, IUG, preterm labor, and risk is also because of previous surgeries done. For example, like adenomyomectomy done, and this patient conceives, she is more prone for, she can go for a rupture during or at the time of labor. So these pregnancies are special. Now, maternal risks in IVF pregnancies, these can be implantation-related risks, like ectopic pregnancies are seen more in IVF patients. Abruptio placentae, placenta previa is 3 to 4 times more common in patients with IVF. Multiple gestation risk is also very important. And age-related complications like gestational diabetes, hypertension, and abortions due to aneuploidies are more common in these patients. There's a lot of psychological impact due to IVF, and delivery-related problems like elective cesarean, Moritz cesarean is also related with morbidity. So psychological factors, these patients, they're under a lot of stress because of, suppose if they have to go for a fetal reduction, suppose one twin die out of 2, suppose there is anomaly in one fetus, suppose they have a twin-to-twin transfusion syndrome, or they have PROM or signs symptoms of preterm labor, and they have to go to hospital again and again. They have a lot of financial burden, their job, their holidays, career worries. So these patients are under constant mental and psychological stress. Now, what are the fetal risk in these pregnancies? Fetuses, they can have more aneuploidies because of elderly patients. They can have multiple pregnancies, they have to fight for their survival. These can, premature delivery can cause fetal at risk, low birth weight babies can born, more miscarriages can happen in IVF. And neonatal mortality morbidity is also high because of prematurity and early deliveries. And there can be sex chromosomal abnormalities in IVF babies if male factor is there. Now, miscarriages, they are very high. If age is more than 40 years, miscarriage rate is more than 35. Between 35 to 39, 1/4 of IVF pregnancies will go into miscarriage. And these miscarriages are more because early and vigilant detection of biochemical, we do very early HCG, and sometimes it is marginally positive and patients, they feel, oh wow, we are pregnant, and then they got periods. So we count them as a miscarriage. Corpus luteum function is there, we know, as I told you in my first slide, because of aspiration of follicular fluid, and age-related aneuploidies are high. And pre-existing diseases like homocysteine deficiency, thyroid antibodies, obesity, nutritional deficiencies, and thrombocytopenia and other factors, they all leads to miscarriage. This diagram shows percentage of aneuploidy with age. More than 40, aneuploidy is very high. This shows age and abortion rate. If age is more than 40, abortion rates are very high. After 35, it is again very high. So all these factors, they affect outcome of IVF pregnancy and make them more important. Now, if suppose a patient had a multiple pregnancy and we miss a vanishing twin, then at the time of doing a double marker, we are not sure why the values are coming abnormal. So it is very important to see whether she has got twins and whether she is having a vanishing twin. And if patient has to go for fetal reductions in multiple pregnancies, the remaining fetuses are at risk. They can have abortion or fetal loss. Spontaneous splitting of embryos is also seen in IVF pregnancy. This publication in 2015 says, although twin pregnancies in IVF pregnancies because of multiple fetal implantation, but monozygotic twins spontaneous splitting is also high. It is 2 to 12 times high in IVF pregnancies as compared to normal conception. Now coming one word about caution about NIPT. NIPT is very accurate in identical twins. It is also accurate in dizygotic twins when there are two placentas. We can find Down syndromes, but if it is more than 3 pregnancies, it is not advisable to go for an NIPT because multiple placenta can make it difficult to give a positive, accurate result. Now, IVF pregnancies are more prone for OHS also. There can be early OHS, but in late OHS, once the patient's beta HCG is positive, they can land up into symptoms of OHS, and this makes this pregnancy more special. So always, as we all know, use antagonist protocol, agonist trigger, frozen embryo transfer is the answer. We must prevent hyperstimulation by giving just adequate dose of gonadotropin. We must do not give HCG trigger if E2 is very high, and we can use bromocriptine letrozole in these patients if we are predicting hyperstimulation. Now the next questions comes about, are congenital anomalies there more in IVF pregnancies? So meta-analysis demonstrate association between IVF ICSI and anomalies, and they found that these are really high, but they are not clear whether it is because of a cause of infertility or because of procedure itself. But definitely anomalies are more seen in IVF pregnancy. So they recommend a very good level 2 scan to rule out all these anomalies at 18 to 20 weeks. Now, what about congenital heart diseases? So there are several studies, they report more congenital heart disease in IVF ICSI population as compared to natural pregnancies. But some studies have shown no additional risk. But we recommend to go for a fetal echocardiography at 20 to 24 weeks to see if level 2 scans, 4 views are normal, patient is poor, she might not go for this, but we must advise patient to go for a fetal echocardiography. Now, what about prevalence of IUGR? It has been seen that fresh cycles have more IUGR than frozen cycles. An increased risk of SJ babies is documented for singleton IVF pregnancy. And they have shown, meta-analysis have shown that higher incidence of SG babies in IVF ICSI pregnancies from fresh cycle as compared with frozen. Frozen has got less IUGR as compared to fresh. So a routine fetal scan and eye over fetal growth is very important in IVF cycles. Now, what is the prevalence of spontaneous preterm birth in IVF ICSI pregnancies? A meta-analysis of singleton IVF pregnancy demonstrated that IVF is associated with higher odds of preterm deliveries, low birth weight, and very low birth weight babies as compared to naturally occurring pregnancy of same age. And this risk is double if patient is having twin pregnancy. There is more incidence of neonatal encephalopathies and perinatal mortality. So there is increased risk of preterm in all these pregnancies. So it is very risky one, and we must keep an eye. Increased risk of very low birth weight babies. More fetal neonatal encephalopathy if patient have a preterm delivery. This risk is double if patient is having twin pregnancy, so we have to be more careful. And it is advisable to do a cervical length measurement with NT scan, anomaly scan, and fetal echo. And if it is less than 2.5, we have to take an action. Routine progesterone supplementation is recommended till 12 weeks only. But if there is any other factor suggesting preterm, risk of preterm, we can further give it for the longer time. Now, what about PIH? So we all know this gestosis score, which our ma'am is passionate about everybody to know this score. And if the score is more than 3, so you can see there is a conception with IVF is already #1 score. So naturally conceived pregnancy, they need 3 scores. But IVF pregnancy, they just need 2 scores to be more careful for prevention of PIH. And it has been seen that there was a study which includes 4 lakhs women, and they found the risk of preeclampsia in women undergoing IVF is compared to natural conception is really high. And women undergoing ART has a small increase in odds of preeclampsia in their second and third pregnancies also as compared to women who did not require ART. So what about echosprin? Should we start in all the patients? No. If we find more than 1 risk or 3 risk as in gestosis score, then only we should give echosprin. Routine echosprin in these patients is not recommended. So this is about echosprin. So now what about PIH in oocyte donor cycle? It has been seen that in oocyte donation, the risk of PIH is 4 times higher as compared to natural conception, and 2 times higher as compared to IVF with patient's own eggs. So oocyte donation is a risk factor for PIH. Is the prevalence of stillbirth is increased in IVF pregnancy? So pregnancies conceived achieved with IVF has 2 to 3 times increased risk of stillbirth even after controlling maternal age, parity, and multi-fetal gestation. So given the increased risk of stillbirth, we suggest a very close monitoring after 36 weeks of pregnancy and till patient delivers. Now, what about PROM? PROM risk is also very high. Two systemic meta-analysis, they showed that pregnancy with ART, they have more PRM as compared to spontaneous conception, both in singleton and multiple pregnancy. Even if it is singleton, the risk of premature is more. And what about placental abnormalities? All types of placental abnormalities like bilobe placenta, accessory placenta, placenta previa, marginal placenta, filamentous cord insertion, everything is more common in IVF pregnancy. And we must do a TVS at 32 weeks to rule out vasa previa because these patients can bleed. And we must do a very good ultrasound to see where is the placenta, where is cord, and to rule out all types of placental abnormalities in patient conceived with IVF. Placenta previa is 3 times higher in patient who conceived with IVF as compared to normal spontaneous conception. Maternal morbidity. So there was a study done between 2008 and 2012, and they found that severe maternal morbidity was nearly twice as likely in pregnancies conceived with ART compared with non-ART patients after controlling maternal age, parity, comorbidity, everything. So maternal morbidity is also high. So we have to keep motivating these mothers not to take complete bed rest if not required, eat healthy, about their weight gain, about their diet. Now coming to the perinatal mortality. Perinatal mortality is also 4 times high in patients who conceive with IVF because of low birth weight, premature rupture, and other causes, multiple gestation. So we have to be very careful about perinatal mortality also. Stillbirth rate is also high in these patients. And so it is very important to counsel these patients that see, you can have a worsening of pre-existing medical condition. For example, if she's conceiving with post breast cancer or she's conceiving after post-renal transplant or any other medical disorder, then that can get worse, number one. Number two, she's at more risk of having anomalies, more if she is of elderly. There is a risk of multiple pregnancy, even if single embryo is transferred, it can split. There is a risk associated with advanced maternal age like diabetes, hypertension, and other diseases. And she can have a lot of psychological, she needs a lot of psychological support. So a proper fair counseling is very important before going for IVF. All these methods which we know, clinical assessment, ultrasounds, and growth and weight, they all are important to do antenatal screening. And now we should, there is a shift of investigations. The pyramid is now inverted. We can do maximum screening at 12 weeks. We can even see tricuspid ejaculation. We can even see, count all the fingers. Mostly we can do a very good fetal scan and we can diagnose if there is some anomalies there. Secondly, we can also do PET screening, biochemical screening for eclampsia. So it's a good idea to do maximum screening in 12 weeks and see what kind of care this patient needs in later trimesters. Other things of caution, always do 75 grams oral glucose test, always do a gestational score for eclampsia, rule out placenta previa, do urine culture and rule out asymptomatic bacteria because this can give them PET and preterm labor. And we should also do chlamydia testing if required. Antenatal care is done in the routine way, but fetal echo should be done. And third trimester, she needs a close monitoring because there is risk of preterm labor, risk of sudden stillbirth. So pay attention to fetal growth. If required, do ultrasound screening, depending upon clinical findings. And in pregnancies achieved with IVF, does delivery at 39 weeks reduces the risk of adverse perinatal outcome? So this is a big question, when to deliver them. It is currently unknown whether elective delivery cesarean section at 39 weeks reduces the risk of maternal morbidity and improves perinatal outcome in IVF pregnancies compared with expected management. A systemic review revealed that asymptomatic, uncomplicated, singleton gestational induction of labor between 39 and 40 weeks 6 days does not increase the risk of cesarean delivery with expected management. So we can wait, but same time, it does not reduces the rate of adverse perinatal outcome, including perinatal death. low Apgar score, and need for ICU admission. So when to deliver these patients, we should give a proper data, and it should be a consensus between doctor and patient. And this, what we say that there is risk of stillbirth and everything has lead to all these pregnancies will end up into muhorathalasias. So muhorathalasias is very common in these patients, which gives morbidity. We know normal delivery is more safe. And postpartum care, again, patient needs a lot of mental support. They are very, very finicky how to feed the baby. Baby ke heartbeat तेज हो रही है, ये हो रहा है, lactation problems. We have to deal with comorbidities, start the treatment which was stopped due to pregnancy. And these patients need a good neonatal care also. And a little bit about caution in IVF pregnancy, be careful because sometimes it is easy to miss twin pregnancies at the time of doing 7 to 8 week scan. Don't miss twins. Don't do over investigations, and do early detection of growth retardation. Patient might need steroids if we know she might have to go for a redeem. So be very careful, and wrong estimation of gestation it should not be done. So to conclude, these pregnancies are really high-risk pregnancies. These patients are under a lot of mental stress, and there should be more vigilant diagnosis for twins, anomalies, IUGR, preterm, etc. They should be screened for medical disorders, and prophylactic treatment should be given whenever required. Timing and mode of delivery should be done according to patient's clinical scenario. Pregnancy support treatment should be given up to 12 weeks, mainly progesterone, and if required can be extended. And single embryo will save most of the complications because splitting is always not there. Thank you so much.
Thanks, Dr. Sujata, for
The problem is how to exit this.
Stop sharing.
Is it stopped now?
No, it's still there.
Okay. I think I will exit and come back again.
Yeah. Dr. Vandana?
Yeah, thanks, Dr. Sujata. Very well presented. Because these women are elderly, so elderly medical conditions definitely would add on to the problems. Secondly, they have been infertile, so there was a basic cause for their infertility. That will also play a big role. And obviously, the neonatal and antenatal complications, with the fetal complications, they all add up to the misery of these women. And psychosocial factors, because they are elderly, they are so scared. They're so scared at every stage of pregnancy that we might lose it, we might lose it. So that scare keeps on going on. And once the baby is born, then they also again start fearing the loss. So the psychological support and lots it's required. So vigilant monitoring, vigilant counseling, and follow-up care would definitely go a long way in giving a successful pregnancy in such patients.
Thank you so much, ma'am. Dr. Nisha?
Yeah. I think Dr. Sujata presented very well. Beautiful talk, Dr. Sujata. And thank you, DGF, for giving me this opportunity. I believe that, okay, fine, the patients are scared, but I think the doctors are more scared. We want to increase our chances of success. We want to increase our success rate. So sometimes there is a problem of overdoing also. We try to stimulate more, we try to prepare, give more estrogen, we try to give more progesterone. I maybe it's like, we have to balance it out. And I think that if we try to do just the optimum, don't overstimulate, don't try to give the minimal dose, then even then we can reduce these chances. Even progesterone dose also, we have a tendency to give all forms, because we don't know which patient is going to respond in which manner. So I think optimization is one thing. Second thing is that it also, the IVF pregnancies, also the care depends upon the indication. For example, a young girl with a tubal factor, maybe her pregnancy is going to be as normal as a normal pregnancy. But an elderly lady who already is having difficulty in conceiving, maybe for her we need to be more cautious. So everything like a dictum in infertility, nothing applies to everyone same. So we just have to make our selection. Thank you so much.
Dr. Pancham?
Thank you, ma'am. Actually, I would like to start. Every pregnancy is precious. That's how we learn. But yes, this carries IVF pregnancies carry with them the stress issues, the anxiety issues. They have so many years of marriage behind them. So yes, they have that thing, and we have to be empathetic about that. We have to have empathy and deal with them with TLC, tender loving care. Yes, we need to keep our radars up. We need to keep them on frequent check. And what we observed is after 28 weeks, once, as Dr. Sujata ma'am clearly said, there was a study which said that ODET pregnancies are predisposed to preeclampsia or not. Yes, it has been seen. We clinically saw after 28 weeks they land up with preeclampsia. We have to be more cautious over them, and they have the BHK, KFT. They might have increased chances of abruption also. So we need to be more vigilant about that, and we need to keep them under check. Also, I would like to emphasize that many a times postpartum, like post-cesarean or whatever, post-delivery, we need to be vigilant. We need to do the BP score and give thromboprophylaxis accordingly, which is very important. We tend to forget. So these are some of the points. And also, I would like to emphasize that there is no role of prophylactic in circulage. Many a times we encounter that patient has been given a stitch because she was an IVF pregnancy. So there is no role of prophylactic in circulage, and only if history indicated or ultrasound indicated in the backdrop, then only we will go in for as per the guidelines.
True.
And the
Thanks.
excellent prior presentation by ma'am. She has actually covered everything. Thank you so much.
Thanks, Dr. Pancham. Dr. Tejashri?
First of all, thank you, Dr. Sharda Jain ma'am and Dr. Shalini ma'am for giving me this opportunity to chair this important session about pregnancy in IVF. And congratulations to Sujata ma'am for covering this exhaustive topic in detail. Just one or two points, and I think Dr. Nisha ma'am and Pancham and Vandana ma'am has covered all the points thoroughly. But one just additional point I wanted to add was that, there is a risk of increased gestational hypertension in these pregnancies. And to prevent that, we have now moved to a natural cycle frozen embryo transfer, wherein we are taking benefit of the corpus luteum, which secretes relaxin. And these cycles, when we do a natural cycle transfer, are found to have a lesser incidence of gestational hypertension. Also, the progesterone point was very, very validly covered by Nisha ma'am. And that's why if we are very, very judicious in using the progesterone support, the IHCP incidence in IVF pregnancies comes down. So I think these were the 2 points I wanted to highlight. Thank you so much. And it was a really enlightening session.
Thanks. Dr. Sujata, one point I would like to highlight. Yes, definitely IVF pregnancies are high-risk pregnancies, but there is a reason for it. These patients are elderly, and because of the age and maybe because of the male factor, so all these incidences go high. In young patients, drastically the incidences of such abnormalities are not that high. Maybe, because age is a very important big factor, and IVF pregnancy is usually present late. And Tejashri very well said,
you are
and
very right. But even in young patients, the overall incidence of sudden stillbirth and preterm labor is high as compared to they have.
Yeah, Dr. Sujata, but not that dramatically high.
But yeah, definitely.
Yeah. So we conclude this webinar, and I would just like to say that we had almost 98 presentees at one point. Yes, by the end of the day, the number certainly goes down. So that number speaks itself. So thank you, Sharda ma'am, for giving us this opportunity to take this forum forward every month. And I sincerely thanks all the chairpersons, all the speakers for doing a wonderful job. And Dr. Sunita, any last words from you, or maybe Dr. Sharda Jain ma'am or Brigadier?
I think this forum is getting popular. Brigadier Sharma and myself definitely thank you for the same. And it is all the kind of topics which are chosen, and the person who is speaking probably makes a lot of difference. And I can see that a lot of younger people are there as a chairman for comments. So whatever deficiency are there in presentation are complemented by the chairman's comments. Wonderful show today. I'm very glad about it. I can say for IVF, one thing is that they definitely require extra care. And we don't overdo it, but the second trimester is one period which definitely requires a very close follow-up in such patients. They do have IUGR problem, they have a decreased Leica, and that kind of problems have to be properly managed. Goes without saying that gestational diabetes and gestational hypertension are one thing which, if you screen them well around 12 weeks, they will not pose much of a problem. Obesity is definitely a big factor in such patients, so it becomes a high risk factor for themselves altogether. I think, Madam said it is nervousness of the doctors. No, I will not say it. I think there's a lot of pressure on the family. is there, and one should not succumb to that kind of pressure and should take independent decisions. This is what I can say. Dr. Sharma, you want to say something, sir?
Thank you, madam. Firstly, I'm very happy the Pancham brought out tender loving care, because these are the patients, they require tender loving care. And moreover, like we should not follow the routine antenatal, checkup. Okay, you come after 1 month, then after 7 months, after 15 days. So we should be approachable to these patients, and if you have any symptom, come early. And rather than, just coming after 1 month only and then 15 days or 1 week later on. Because many times, they have some symptoms, and if they come early, we can detect the problem early, and they can continue with the pregnancy. So their antenatal checkup should be, dependent on what is her problems, rather than routine antenatal checkup we are doing for the other patients. So this is very, very important, because otherwise, like a patient comes to you, I'm having mild pain. Like, if you are too strict about, oh no, you come after 1 month only, I've seen you 1 month back, why you come early? So, you may miss on into the early, labor she is getting it. So we should tell the patient that whenever you have any complaint, please come immediately, so that we can detect the problems early and treat them. Because some of these patients, have all the complications. Like I remember a patient having, blood cancer during pregnancy, during IVF. But just imagine, ladies, it's very uncommon to have blood cancer. That too in pregnancy, she had it. And similarly, the one lady had a frank, a brush of the Sunday immediately, because she did not come, because when she was having mild pain, she did not come. And she came when she herself was in a shock. So I think that is a thing that from the beginning only we should guide the patient that please come as and when you need us, not as when we are calling you. So that is a routine, okay. But in case you have a problem, please come early.
Thank you so much, sir, for your wonderful and concluding remarks. And with this, I think we all take leave, and with sincere thanks to every one of you present there, to all the delegates who've been glued till the end, and thanks to Malti also for staying till the end, for coordinating all the webinars. Thank you so
Those
much.
who want to go to Jhansi, please give your name. You young girls, give your name. Suyesha.
Good.
Yeah.
Thank you so much, ma'am. Thank you. Thank you, sir.
Okay, ma'am. Bye. Bye.
Good evening. Good evening.
Bye for now.
Yeah, thanks.